One of the things we are asking people is that if they've got a conflict of interest, and perhaps you could fill in a paper after this session to say what your conflicts of interest are. So as we're a bit short of time, perhaps we could just start off, unless you want to tell us anything particularly about your individual trusts or anything you want to say, or should we just stop questions? All right. Okay, thanks very much indeed. One of the questions that we're putting to everybody now, since the new NICE guidelines have been published, we wondered if you had any view of those, if you think that they are clear and precise, and whether you think they could have been improved or adapted or whatever.
I have to declare a conflict because I was...
Sorry, you're going to have to speak.
Sorry, I have to declare a conflict because I was the clinical lead for incontinence on the NICE guideline.
Oh, right, okay. So you obviously think they're perfect?
I think with the evidence available, I think it was the best that we could do, and using the expertise of the committee that we had, then I think, you know, that nothing's perfect and they never will be perfect, but I think, you know, I think they're reasonable, and we would have liked to have had more evidence, particularly about complications, and I think that was part of the problem with writing the guidelines, was a lack of...
I don't have a conflict of interest that I'm aware of. I think they're quite reasonable, particularly if you take in mind the mechanism of creating a NICE guideline, which is very mechanistic and depends on the literature that's available.
Right.
And that's the issue, I think.
So it's about resources, you say?
Well, it's about publications.
It's about what exists, yes, and the problem being that there wasn't a lot of evidence of long-term complications of any operations, whether they were mesh-related or not mesh-related, and I think that was part of the issue.
So you're saying that's a common problem right across the board, and it's not specific to this area that we're looking at?
Yes.
Because of course one of the things that women would tell us over and over again, if there isn't the evidence to say this is something that's going to be in our bodies permanently, how can anyone declare that it's safe?
Yes, and I think that also sutures are in their bodies permanently from other operations, so there are long-term complications of all surgery, and you know, I think that one of the concerns is that patients haven't been aware of what's been put in their body, and I think that's a really important thing. But also, you know, we're also in danger of then not being able to do any operations at all and not offer people treatment for quite a horrible condition because we don't have evidence for any of the operations in the longer term. And I think that's quite a difficult thing as a doctor to say, you know, we want to give some guidance, and the important thing is that we are as transparent as possible to patients, and that was, I think, what was aimed to get out in the guideline was as much information to people to make their own decisions.
And to be clear about what we or you as doctors don't know as well.
Yes.
As what you.
Yes.
Do you think the NICE guidelines adequately ensure that is going to come out through a consent process?
Well, a consent process is always an individual process between one or several doctors and one patient. So, I hope it does, but it is an individual process.
But it should, yeah.
With the more standardised things like patient decision aids, that should presumably standardise the consent process and make sure that everyone has at least a minimum.
Yes. Yeah. I mean, as a urologist, I now use all of the BAUS information sheets, and I literally give the patients a half-inch thick wad of A4 at their first appointment. So they usually come back and say, "There's too much information. What would you do?"
Yeah.
So where do you go from there?
So can I just ask you, because we've invited you here for lots of reasons, but clearly you're people who are actually having to deliver the service to your populations. And I'm very interested in what you say about getting the patient's consent, It's a big issue that's arisen, as you can imagine, with patient groups with us. And one of the suggestions have made to us is that there would be an opportunity, perhaps, at that first interview that you have with the patient, that you could record it audibly, so you could do it on an iPhone or something like that, so they could then listen to what you've said, take it away with them, talk to their family or friends or whatever, because it is a lot to take in at the first interview they have with you. And then I'm sure there are other questions they might be triggered once they've listened again to the initial interview, and they could then ask you more questions.
Mm-hmm.
Do you think that's a possibility?
It's certainly a possibility, but it runs up against practicalities in the NHS, I'm afraid.
It runs up against what?
Practicalities in my NHS life, which is extremely busy, overrunning clinics, lack of peace and quiet to actually sit and record an interview.
But you said that they come back to you anyhow.
Yeah.
So they could come back to you having listened
Yes.
to this interview,
Yes.
and that might have triggered some more questions, which might be helpful
Yes.
to you, in order to help
I'm in
them
favour of it, yes.
reach a decision.
Yeah.
Okay. Can I ask you about, again, the NICE guidelines and the fact that they're recommending an MDT team. Can you tell us a bit about your teams, your multidisciplinary teams?
So we have a team for our primary surgery. It's a sort of core team for our trust. So we've got a trust that's made up
Karen,
of...
I'm so sorry, I'm going to
Sorry.
interrupt, because I should have
Yes.
said at the very beginning who you are.
Oh, sorry.
And why you're... No, it was my fault. So perhaps you could just say...
So I'm consultant urogynecologist, Manchester.
And Manchester is the biggest unit in the country.
I think it's one of the biggest. Yeah, we have
One
5
of the biggest.
subspecialist urogynecologists. We have a couple of urologists. We have colorectal surgeons. We have 5 colorectal surgeons, 3 radiologists, plastic surgeon, and pain specialists. So it's a huge team, but we don't always meet at the same time. So it depends on what we're discussing, whether it's mesh.
I'm just going to ask then, Mr. Fulford.
So I'm Simon
Just say who
Fulford.
you are.
Yeah, I'm Simon Fulford. I'm a consultant urologist in Middlesbrough.
Right. Would you like to continue about your MDT?
Yes, we have a huge team,
Yes.
but practicalities, because it's expensive to have everybody sitting in the room at the same time, and that's one of the problems, is job planning a huge number of people to all sit in the room. So we try to take a practical approach to that, which is to have the people that need to be there. So we have the fairly straightforward cases, primary surgery, that we deal with every week. So we have a whole morning a week that we spend in our MDT. And then we'll have additional MDTs with whoever needs to be there, so whether it's a pain specialist, which is usually about once a month, or radiology and urology, all of those are about once a month, depending on what patients we have, because it's just not feasible to have an MDT of everybody sitting there at the same time. It's a very expensive service to run, and so we've got to try and make the most of people's time by not having them all sitting there for a whole morning if they don't need to be there.
So you use other methods of communication, do you?
No, we limit it to about once a month with the extra people, so the more complex things. And we are in the process of organising teleconferencing for our outlying trusts.
Right. And so that works quite well. Does it work for patients?
We write to them so they know that they're going to be discussed at the MDT, and then at the end of when we've discussed it, we dictate a letter back to the patient to let them know what we've decided. So we'll have had a conversation with them beforehand and assessed them, and we'll have had a conversation with what the options might be, and then once we've discussed it at the MDT, we write back to them to let them know what the plan is going to be and when they're going to be seen. And we might telephone them if they come from a long way away, or we might see them back.
And you don't have the patient present when you're discussing the options
No.
that are available?
No.
Is there a reason for that?
logistics mainly. So some of our patients come from a long distance. It would be quite difficult to time that, and also the availability of different people. Sometimes it doesn't happen exactly when you think it's going to happen. So I think it would be difficult to do that, but not impossible.
So you could give it as an option, and
It
then
would
if
be-
they can't travel or can't get there, that would be their decision.
I think it would be a challenge to do that, because it would take longer, because obviously you can't use lots of shortcuts in your conversations, and so I think it would be a lot more resource intensive to do that if they were to attend. But there wouldn't be a reason why they couldn't come, but I think it would be difficult to organise that.
Or MDT.
Right, our MDT, we have there's 2 consultant urologists, myself and a colleague. There's 2 consultant urogynecologists who do nothing but urogynecology. There's an associate specialist in urogynecology. There is, we have 2 interested colorectal surgeons who attend, one of whom does the majority of his work is functional work. We have a radiologist with a particular interest in pelvic imaging. We have a specialist physiotherapist and a couple of urology nurse practitioners and a urogynae nurse practitioner. I'm trying to think who else is in the room, and some trainees. And that we meet over lunchtime once every 4 weeks, and we discuss. We aim to discuss all new stress incontinence cases amongst all the other prolapse cases, urethral diverticulums, a whole variety of things. And we do have a liaison with our pain specialist. One of our pain specialists occasionally, will attend if we ask him to.
Right, and again, you would find it difficult to have a patient present, would you?
We would, I think, because of the timing, the nature of the meeting, and the number of patients that we're trying to put through. It's possible it could be arranged. I think just on a practical basis, the room that we use at the moment would probably not be terribly user-friendly for patients sitting outside and so on, but it could be done.
Right, okay.
Can I just ask something about it?
Yeah.
So the NICE guidelines have come out, but as is recognised in the NICE guidelines, the pause and the high-vigilance regime continues.
Yep.
A couple of questions around that. Firstly, are you confident that both within your own trust, but more broadly, that situation is understood?
Yes. Very confident. Within urology, I was surprised to see the guidelines. I was surprised they were published before your inquiry was published. I wasn't expecting that to happen. And within 48 hours later, BAUS sent out an email from Chris Harding saying, hang on guys, the high vigilance is still in place, this isn't the green light.
And the other question that we'd be interested in your views on in relation to the pause is, how are you managing patients who, were it not for the pause, you might have been recommending mesh-related treatments to? I wouldn't go as far as I'm recommending mesh-related treatments to anybody at the moment, but it is one of the options that we would discuss. And if they choose a mesh-related, if someone, as happened last week, said, I really quite want a TBT, please, Mr. Fulford, I just said, well, that's not currently possible, why don't you come back and see me in 6 months? And I also did a rectus fascial sling on a lady yesterday who wanted a TBT just before the pause came in place under a colleague, but decided she'd go on holiday instead, came back and was told that she was no longer on the waiting list to go and see Mr. Fulford. So those are the 2 routes that people are taking.
And what proportion of people are waiting and what proportion of people are having alternative treatment?
A minority of people are waiting. There's only a few. In fact, there's one group, a minority of ladies are waiting. I have quite a few men who are waiting for an advanced sling. Who've also been caught up in this.
And our experience is similar, so most of our patients have opted for a different procedure. I think I don't have anyone waiting myself, but my colleagues may do, but it's only one or two, and most people, we brought them back and counselled them, and we wrote to them all to let them know what was happening last July, and then we brought them all back to clinic, and they've all been operated on. The majority have had something else.
Is this more autologous slings or?
Yes, so either copper suspension or a sling, most of them. And then there are the group under the high-vigilance procedures that are having prolapse surgery with mesh, and we are writing to them when we've discussed their procedure to let them know it's a high-vigilance procedure, and we're obviously conducting an audit of all of those procedures that we're doing.
But you wouldn't expect a huge sort of, when the pause conditions are met and it's lifted, you wouldn't expect a sort of influx of people who've been waiting.
No, I think our practice may be slightly different from other hospitals around the country, but we always had a higher number of patients having alternative procedures. So, and we'd already seen a big drop in mesh procedures before the pause. So we were seeing that nationwide. The TVT was dropping. So we'd already started to and seen patients opting for alternative procedures. So no, I don't think there is in our practice.
So does that mean that the expertise within the team, both your teams, to provide alternative surgical options, autologous slings, copper suspension, that's already available? It's not like you've had to reskill yourselves in order to do that?
I've had to train my colleagues to do it.
Right.
Because my main role is in urology, looking after spinal injury patients and so on, in whom I've continued to do rectus fascial slings forever. So when this occurred, my urogynae colleagues were going, well, how do you do a sling? And we had conversations, we've operated together, and we're now all up to speed.
Can I just ask you about the high vigilance? What sort of numbers are you having in terms of operating through the window, if I can describe it as that, of high vigilance?
Well, it's difficult because we've increased our number of consultants recently, but the high vigilance procedures, so the slings and the copper suspensions, we're doing a few of those every week on our theatre lists. We're doing fewer prolapse, abdominally placed prolapse meshes, which come under the high vigilance, so they have dropped. So sacrocolpopexes and sacrohysteropexes have dropped. So, but it's predominantly under high vigilance. It's bulking, copper suspensions, and slings that we're doing.
It's difficult for me to comment on how the activity of my urogynae colleagues is in terms of prolapse, but they never really did very many meshes at all, and they're not doing any. They are doing some sacrocolpopexes, sacrohysteropexes, often as joint procedures actually. I've been involved in a couple of those recently, and we're all doing more bulking agents and more slings and the occasional copper suspension.
Thank you very much. When the women that come to you hear about the pause and all the rest of it, do you get any sort of feedback from them about the pause? Are they deeply disappointed, or they understand why the pause has been introduced? Do you get any feedback?
Not really. I think most of them know before they come what's happening. They've heard about the mesh situation, so they're coming knowing that already. So no, I think they don't seem to. I think they seem to value our transparency in telling them what's happening and the reasons for it. So I haven't really had any negative in patients I've spoken to.
I'd say the patients I deal with fall into two groups. One, the sort of naive patient who comes with a problem and discuss things and they react in exactly that way. But I also get reasonable number who come along because their friend had a TVT done by me a few years ago, and they are quite upset that they are now being blocked from having that option, and that's a huge issue in the men as well, with the advanced sling. The number of men that I see who come along and say, I'd really like a sling, and you say, well, you can't have one at the moment, and they ask why, and I explain, and they go, well, but I'm a man, I don't have a vagina, what's that got to do with me? So that's a different group. It's not big numbers, but they are disappointed about it.
I think it though depends on your own individual hospital circumstances
Yeah.
and referral patterns. So the patients that tend to come to us are people who have come because they know we can do the other operations, or they've been referred in from other hospitals because they know what we can do. So we probably see a lot fewer of those kind of patients who have, his mother had a TVT and now wants
Yeah.
one. We just don't see those kind of patients. They've come specifically because they know we can do an alternative.
We have, in terms of certainly the continence side of it, the 5 people I mentioned in our MDT are the only urologists or gynecologists on T side. Sorry, that's not quite right, because there are urogynecologists in peripheral hospitals who actually do feed into our MDT and occasionally attend that. I forgot to mention them. But so there's 7 of us, I think, on T side, which has a population of about 1 million who do continence surgery, and we work within our MDT network. So everybody should be aware that all of the options are available.
And in terms of the surgical alternatives to mesh, what's your view and experience of relative risks and benefits compared to mesh?
That's a big question. Obviously there's been a 20-year gap of people not doing those previous procedures, and there was a reason, I suspect, that midurethral slings became so popular. Not only were they perceived as being quicker and easier and quicker recovery, but we did know there were complications with the other procedures. So I think that's the issue really, is that those procedures haven't been done for 20 years, and the quality of the evidence from 20 years ago looking at complications from those procedures is not good. But we did recognise that patients having, for example, a colpo suspension had a higher risk of getting a prolapse afterwards. That we did recognise. It wasn't a procedure that was necessarily completely straightforward, and I think the technique may well have changed a little bit, but we also saw people had difficulty emptying their bladders. But when you actually look at the comparative studies, there's not a huge difference between the TVT and the colpo suspension apart from in prolapse. Slings, I think, have gone through changes, and I think the other issue here is that the operations that were being done 20 years ago have been modified in that time. So the original sling operations would have been, big operations, the Aldridge type sling, a big operation, and it's now become a lot more similar to a TVT, except done without the mesh, so done with the tissue from the abdominal wall, and so we're not really, the numbers haven't really come, and the studies haven't come in to really get to the bottom of whether they are, the safety of those, because the longest term data we've got is probably about 10-15 years data on fairly small numbers done in one trial. So, my feeling is that we had a lot of complications from doing Aldridge slings. We didn't do big numbers, but we did have patients with hernias, and that's the big problem for patients who don't want mesh, is if you give them a hernia, then they can be quite difficult to repair without using a mesh, because they're very low down hernias. So, by changing the technique, we hope that the complication rate will go down, but they certainly do take longer to recover, longer to get back to work, and there is a question mark about the comparative safety of them.
And if now, under the pause, you are offering alternative procedures that are surgical, should they fail, and then the pause does get lifted to say, does the fact that that procedure has failed, does it compromise the outcome for the mesh procedure further down the line? Because there is this debate, isn't there? And we've heard from the women's groups, we actually want to see mesh as the third and last possible option. Guidelines and providers didn't say that. But there is this question, on the other hand, is that if you do go down the secondary line of surgical procedure, which isn't mesh, how might that affect the outcome if that failed for a subsequent mesh operation that you might need? And I'm not sure.
It's a difficult question to answer because there aren't any good studies of surgery for recurrent stress incontinence. So we know that mesh procedures, or specifically retropubic mesh procedures, do work for recurrent stress incontinence, as do slings, and they were traditionally the procedures that were done, maybe bulking as well, for recurrent stress incontinence, but we don't know enough about the prior procedure. So we're going to have a huge cohort of women who have had a retropubic or a mesh procedure having surgery, but actually looking at people who have had Colpo suspensions and slings and then seeing what their outcome is, I'm not sure that we're going to get that. My feeling is that probably, I don't think you can say. I think we know that when you do surgery for recurrent stress incontinence, the success rate for every operation is lower. So you might say an 85% chance of success for the first operation. You go down to about 60% if you need more surgery. But I don't think we've got that level of evidence.
No.
Unless you know it.
No. But
Can I ask about removals?
sorry, could I answer that question, the previous question?
Sorry.
As someone who actually did my primary research into slings 20 odd years ago, I've always been a proponent of slings rather than Colpo suspensions. But both are very morbid operations, and both have a high long-term failure rate compared to the TVT, which is the standard sling that I was using. The rate of wound infections and, as we said, prolapse are quite significant with both operations, and the lady's recovery from having a TVT compared to having a rectusfacial sling is a few days versus 6 weeks. I mean, it really is chalk and cheese. And I think it's very important that that's understood by patients and everyone else. In terms of recurrent stress incontinence, the first chance of resolving something is always the best, and I would agree that of the mesh options, a TVT would always be the option for recurrence, but generally if someone had recurrent stress incontinence, you would be recommending a sling, a rectusfacial sling, and I frequently do those for recurrence for all sorts of stress previous procedures, and then they're not easy, they're more difficult, more morbid, and I really don't think I would be recommending mesh for redo procedures. If someone had, which I think your question was, a sling before, then trying to do a TVT with all of the scarring and so on, I think would be more difficult, and my gut feeling would be there'd be more issues with erosions and so on. So the patient's wish that it's the third option is not in keeping with what we know about the device, the procedure, in my opinion, based on no particular written down evidence but experience.
I just wanted to ask about removals, and I understand in Manchester you do quite a lot of those removals. I don't know about South Tees, do you?
We do. I don't know, in my submission we included our data from 924 patients that we had operated on ourselves, and our rate of actual problems seems to be an awful lot lower than we hear about from elsewhere. Whether that's because it all seems to be kept in-house amongst the same cohort of surgeons putting them in, I don't know. So we are removing tapes, but very few, relatively speaking.
Right. And Manchester?
We have a lot of patients referred in from elsewhere having mesh removal, yes, from the northwest and the north of England.
And you don't see any sort of concern where you're inserting mesh but also you're removing mesh, because some of the patients are worried about that?
Yes. I think there are there are different there are different types of mesh, things that we're getting referred in, and I think that is it is a difficult one to understand. But within the pause, we're still inserting mesh for prolapse operations, and I think for some of those women coming with really big prolapses, recurrent prolapses, the alternative to offering them mesh is for them not to have surgery, often, or have their vagina closed because they've had all the other operations. So even though I think we need to be as transparent as we can, and the patients understand what the options are. The difficulty specific with prolapse is that the options can be really limited, and these women have got quite significant symptoms, big prolapses, and if we couldn't offer them a procedure with mesh, or their vagina being closed, then they would have to just live with their prolapse, and that's quite difficult.
And you don't see a conflict between your colleagues who are putting in mesh and others who
my colleagues are no longer putting in vaginal mesh. Prolapse mesh. We pretty much abandoned that before the pause happened because of our disappointment with the results. We do, as I said, sacrocolpopexies and so on. But again, it's a matter of what is the alternative. And if that's not palatable to the lady, then accepting the risk, taking on board the risk, seems reasonable. And I think if we're, to put it a different way around, if we're prepared to put them in, we should be prepared to take them out. In terms of offering the full skill set and service to the patients.
So I was just going to pick up two things. Actually, there seemed to be a little bit of confusion between what you were both saying, because I was hearing from you that the alternative for some of this prolapse, there is none, but you're saying actually my colleagues don't do mesh for prolapse. So
I think they don't do vaginal meshes. So there are vaginal meshes for prolapse and the abdominally placed, so the laparoscopy or open.
Right.
So I think your colleagues are doing.
Yes, they're doing sacrocolpopexy meshes, but they're not doing prolapse repair mesh.
Right, because that's one of the interesting points about the new NICE guidelines, is it not? But in fact, where previously vagina-inserted mesh for treatment of prolapse was restricted to research only, that has been lifted from the new NICE guidelines. Actually, you're the clinical lead for that, you might be able to explain why.
Not for the prolapse, I was incontinence lead, but I think the very, very few women, if you look at the numbers, very, very few women would actually fulfill those criteria, that they had a recurrent anterior prolapse and they were wanting to consider mesh, and they have good apical support and all those things that there are. And we were looking in our own group of patients in a year, even before the restriction, before the high vigilance and the restriction on vaginal mesh, we hadn't done one, and we're a busy centre. We hadn't put a mesh in we'd done it under the Prospect trial, but we hadn't had someone that we would have considered a mesh for. So there may be one or two per year that we might discuss it with, someone with recurrent anterior vaginal wall prolapse. But again, this is in the context of really having nothing else to offer somebody, and that they may wish to consider that as an option. In practice, it happens so rarely, because often the skin's very thin, the vagina's very scarred, you just really wouldn't want to put a mesh in, but there are a very, very small number of women that might be appropriate, and so that's...
Can I just stick with the removals at the moment? We have heard from women who say, we're going to have a full removal. We've been promised we're having a full removal, we're having a full vaginal removal. And they believe that's what's happened to them. Actually, that's not what happens to them. They go into the surgery believing that's what they've been offered, and they come out, it's quite apparent that they haven't had that. Now, one of the issues is, can you actually do a full removal going through the vagina without the incision in the groin? It's not possible. So if a surgeon is saying...
I can't see how you could do that.
Right, so in effect what you're left with is you're taking out the sort of central skin bit.
If it's infected, you could take it out from the vagina, because they essentially fall out if they're infected, and we don't see very many of those at all, maybe one a year. But generally, if it's a full length, and we talk about obturator devices, if it's a full-length transobturator, then they're about 22 to 24 centimetres long. The vaginal part is maybe 8 to 10 centimetres. So there's a lot in the groin, and it's quite fixed in the tissues, which is why it works. And so I personally can't see how to do that. It may be possible, but you're kind of going up and around the corner into the groin. I don't understand how you can do that.
So in fact you can't do it. If you want to
I
take the
can't.
whole thing out, it is
Yes,
impossible.
I can't.
Right. So
We can't.
So being told one thing and believing that's what happened, and then sort of they're still in pain, and actually they discover later on that they've still got the mesh in them. It's not really surprising, this language of communication,
Yes.
whether they understood in fact what they were being told. One of the things they say is, well, if we were to have confidence that what we're being told is actually what happened, wouldn't it be very simple if every surgeon, when implanting such a tape, were to say it's 24 centimetres long and recording that on their implanting notes? So when it comes to the point at which you remove it, you could actually say, well, I've taken out 8. It's obvious you haven't taken out all of it. And you would know, because there'd be a difference. And they're saying, isn't that a very simple, transparent way of being able
Unfortunately,
to...
that they contract, which is part of the problem.
But wouldn't contract from 24 to 8.
Not to 8, no.
Well, also you don't know how much, what the length is, because the way that the devices are put in is that you trim the mesh at the level of the skin and then lift the skin up, and it drops down at the time. So whether or not it contracts, you don't have a measurement of how much. I suppose you could subtract it from what was left on the introducers, but actually we know that how long a TVT is, and when you get to the end of it, you can see when you're dissecting, when you've reached the end of it. I mean, if we're doing a retropubic removal, we would record the procedure, all of our, with permission from the patient, our laparoscopic procedures are recorded, and we'll ask medical photography to come and take a photograph of the explanted mesh. So we would try and and sometimes you take the mesh and show it to the patient if they want to see it. I think you just need to tell them, and sometimes it's not possible to remove, even with when you go in with the intention of removing particularly an obturator mesh or a vaginally placed mesh for prolapse. It's not always possible to remove all of it.
So you might have said to the woman beforehand, this is our intention. But actually, when it comes to it, you can't.
Yes, and then you have to tell them that you have what you have managed to do, and then obviously have a plan in place for what to do next.
But
it may not be possible.
If you've left bins in and you've taken out the sort of central bit, is it actually then almost impossible to get into the bits that are sort of left?
Yes.
So
especially if the mesh is a colourless one, you can't see it. You're relying on just feeling it.
So does that mean
in amongst the groin muscles?
Right. So there's a sort of compromise to the next step. If they need to get the rest out, the chances are you compromise
But
that.
some women would, yes, and I think that's my worry when obviously we're discussing with patients is that you almost go along a route where they've ended up with a very big operation for something that may not have required it, but they don't want to take the risk of losing the chance to have it removed from the groin. So there will be a large number of women who will respond to just having the vaginal part removed, and you can touch it, it's tender. If you remove it, they will get better. But the problem is, if they don't and you have removed it, then you've lost your chance really to be able to get that groin part out if you need to. And we don't know really how to assess women, and we don't have the evidence of how to assess them and how to predict which people are going to get better and which ones aren't. So we have to just explain these are the options, these are the risks, and come to a...
And so the recovery rate of the complications would be that much bigger for the full removal of the groin incision? And that's why you're saying you wouldn't do it automatically unless the pain or the symptoms presented suggest that's what you need to do.
As Karen was saying, if someone's got pain just in the central portion of it, and you go digging and getting the full tape out, and they have groin pain after that,
You've lost the opportunity. You've made the point about colour of the mesh. Somebody could also say that maybe what we should have is mesh that is coloured if it's going to make it that much easier.
That was in the 2013 guidance, actually.
Yeah. That's a very simple, obvious thing to have done.
The original Gynecare TVT has always remained, well no, it didn't, it
No,
went
it's
pale
clear,
for a
yeah,
while,
it's clear.
but it went back to being blue,
That
which
might
is one
touch
of
on
many reasons for
another,
only using that one.
might touch on another issue we were going to ask you about, which is the role of scans, both MRI and translabial. Lots of women have told us about the importance they attach to translabial scans, but at the same time the difficulty they have in accessing translabial scans on the NHS, and the cost increasing, it seems, cost of doing it privately. And perhaps the unfairness, if they've had an NHS insertion, they end up having to have a private scan to find out where this mesh is. It would be interesting to know your views on the relative merits of translabial scans versus other scans versus no scans, because we understand there are surgeons internationally who don't use scans at all.
We routinely would use an MRI scan as a standard looking at a complicated mesh. Our expert radiologist would do a sort of hybrid transvaginal, translabial, trying to find it sort of ultrasound scan, but she herself is not terribly confident that she's that's terribly useful. So
I mean, I
our
think this is one of
experience is mixed.
another problem, that we don't have good evidence for any of these investigations and what's useful and what's not. With MR, we use that for abdominally placed mesh, and where we might be suspecting infection, so if someone's got abscesses in their groin or something, you can see it on MR scan, an abdominally placed mesh. We do translabial scans. We have 2 consultants who do them in our mesh clinics. And I think they could be useful if someone's had some mesh removed, or they've had more than one tape put in, which is not uncommon, and we can see where they're going, and sometimes you can see them going diagonally. If they're in the urethra, you can see that reasonably clearly, but I'm not sure of the value of it over a thorough vaginal examination. And when I examine a patient, I don't look at the scan result, I examine it and then we'll compare the two and see, and actually clinical examination, if you can feel the mesh, you can usually tell where it's going and where it is if you're experienced. So I'm not sure, and obviously you need to do the vaginal examination to see how tender they are. So I don't think we've completely established the use of transperineal scans. I think they are useful, but I'm not sure we've got any standardisation, and certainly if we're operating on someone, I would rather one of my colleagues would scan them than have a scan from someone in the private sector that I don't know the sonographer. And I think there is an issue with standardisation of the technique of scanning and that kind of thing. I'm not a sonographer, so I trust my colleagues, but there are issues about the quality of some scans.
So should it be a requirement of future mesh removal centres, the newly commissioned ones that will happen later in the year, that they all carry out or are capable of carrying out translabial scans? Should that be a requirement?
Having a dedicated, nominated expert radiologist who could do the appropriate imaging, which might include a translabial scan. The way I'd put it, rather than putting translabial scan as the answer, because my translabial scan is different from someone else's, and it's not standardised.
And it's part of
That's
the whole
a big
assessment
problem.
rather than the most important. So actually assisted arthroscopy might be far more important for some patients than a translabial scan, because you can't see it once it leaves the vagina. You can't see it in the groin, for example. So and retropubically, you're only really seeing it in the vagina. So I think it's part of the package of what we should have available. I think more important is that we actually conduct some research into the usefulness of it.
Can you, with scanning, can you pick up where the mesh has actually splintered and gone away from the original one? One of the things women have been saying to us is that they feel that the mesh actually, not as a whole, but as pieces, breaks up, and then it gravitates into other parts of the body. Have you ever come across that?
No. So I've seen it where it's directly attached to the rest of the mesh, can go into the bladder, can go into the urethra,
yes, but it's
into
still
the bowel.
attached.
But yes, and the ones we've seen that have been detached are people who have had surgery, and you may have a piece of mesh left. but I haven't seen
No.
myself.
But splintering is
No.
nothing that you've come across.
No.
We've heard a bit about that. But you're never quite sure with communications what people are saying. Can I just ask you about the medical device industry? Because one of the things that we've been listening to women, and when we've asked them when they had it inserted, it seems that over the years, urologists have told us that actually the product has improved, the mesh has improved, whereas in the early days it was far less useful in the way that it's been now, because it was different products. And I was just wondering, with your colleagues, your fellow surgeons, have they noticed the difference in the quality of the mesh that's been used, say 5-10 years ago compared to today?
I mean, I think there's a big difference from meshes used in the 1980s and before TVT came along. And I think for prolapse, I think we've moved to a lighter weight mesh so that there's not as much mesh in patient, so they're lighter weight and they're softer. But for continence, I don't think we know which mesh has got the right properties. I don't think we know enough about the properties, and a lot of the devices have a different weave of mesh, and none of that has really been evaluated comparing it to, you know, another mesh. So if you say that the first one was TVT and that would be the standard, we don't know how the modifications have affected the properties of the mesh in the patients. So I'm not seeing anything that I think this is better than the TVT. So I would have been doing a TVT and had never changed from doing a TVT because I knew that's where the evidence was. And that's where the majority of the evidence for retropubic tapes was originally with TVT and the long term. So I haven't changed, and I would need a lot of persuading to know that something was better. And all the manufacturers will have they have to, because otherwise they wouldn't get a patent. But there will be a difference in their device. But I don't know that one mesh is better than the other, because we haven't got any evidence for that at all.
Right.
For incontinence meshes.
I'm just thinking also about the manufacturers. Do any of your surgeons or colleagues actually have any sort of connection with the manufacturers? I mean, we don't have actually a database, do we? We don't know the interests that different clinicians have with different organisations, even in terms of charitable work or whatever. There's no register of their interests, and I'm just wondering if that's something that you think would instill further confidence in patients if they actually could see that.
I think so.
I think it would. Could I just make a comment about the mesh? The only work that's really been done on the pore size, the knotting or welding, the size of the fibre was done by Alfie Onston before he introduced the TVT to clinical practice. He worked it all out. He looked at different pore sizes, he looked at different mesh diameters, knots and so on in animal experimentation, and he chose the material that we use in a TVT because that was the best option in terms of producing fibrosis and not inflammation. He gets onto the market, he does becomes the market leader. All the other industry areas look at this and go, I want a piece of that, but it's got to be different. So they produced Me Too devices using different meshes. It's how the TOT arose. And it's a complete failure of my profession and the industry to do things in a safe way, and I'm ashamed of it. I have never put anything in other than an original GynaeCare TVT. And for years, reps would come and see me and say, Mr. Fulford, you put in lots of tapes, don't you? Yes. Please put ours in. No. Why not? I would like to see 5-year, 10-year randomised control data against collar suspension or TVT. They went away.
That's an interesting point, because one of the things I was going to ask is what control surgeons have over the supplies that are being used within their trust. So there is obviously the NHS central procurement buying system over there. But I mean, as you say, a rep comes and sees you and you might be persuaded that this is the next best thing. Do you go then to say, I'd like to see that on our system and I want that to be used and that's how I'm going to proceed from now on? I mean, I don't know if you have the power to do that.
You could.
You could.
Or you could do what we both have done and said, no, we're not doing that, because that's not where, and that's not where the evidence is. I think that has happened in other hospitals where there's a significant price difference and they look substantially equivalent and they feel the same. But that sort of comes back to the question we were just asking about registry of interest and being very clear. Who has provided or supported a surgeon, for example, with a training or conference or whatever. And yes, that's the particular measure that's being used in that hospital. And that's a real change in surgery. You have the Birch copper suspension, the Aldridge sling, and now we've got manufacturers who are running the training, and all the operations are named after by the manufacturer now. And so that has happened, that the manufacturer will come up with a new device and arrange for training for those surgeons. But for the women, it shouldn't be that random, should it? It shouldn't be, in one hospital we'll stay with what we know is tried and tested, but we'll go. But equally, you want to know your surgeon has been trained in it, because there was nothing really to stop you taking a box off the shelf and doing it. I mean, it sounds horrific, but there technically isn't anything to stop you doing that, or wasn't anything to stop you doing that.
And in terms of different manufacturer products, do we have any way of knowing if one product is superior to another, or if you've got higher complication rates?
I mean, there have been the ones with the higher complication rates have been withdrawn. So you saw different at the time of the TVT introduction. There was another tape called an IVS, which did have a higher erosion rate or exposure into the vagina, and has been withdrawn. So yes, there are differences, but unless there's a head-to-head comparison, and a lot of the evidence is one group of devices versus another, so obturators versus retropubics, rather than one specific device versus another. And I think that's particularly the case for the mini slings, the ones with the single incision slings with the little hooks or devices to anchor them, is that they are all completely different. If you look at them all, they're all different. So they're very difficult to aggregate the data together, and you shouldn't really, to know what the complications are and whether they work.
But the usual argument was, well, it's the same as a TVT, but it's different. And have five free and see what you think. That's the sort of line that you get. Try it out.
Can I ask, if there was to be a safety alert for any of the products, any of the mesh products that you've been using, if there had to be a recall, could you actually do that for the women that have been treated in your hospital?
Yes.
So you would have
But
the means
by
to
device or by operation?
By device, so there's something about a recall.
Yeah, I have 5 years worth of patients' data.
And you could find
the operation. We would have to go several steps back to get to what was actually put in. But it would be very simple. If my name's on the operating list, it would be a TVT.
So those of us who have stuck to the same device, it's
but
relatively easy because you just get everyone who's had that procedure.
If other colleagues have varied the device, the particular brand that they use, then unless they recorded that at the time.
Yeah, but it will be recorded in the operation.
But would you have to go back to the original notes? Not those
Probably.
Paper in the old
Well,
case.
going back to, not that I've worked in my trust for that long, but you would be going back to the early 2000s, so they're unlikely to be electronic records for all those.
So to
It
do
would be
that, you
difficult.
have to
It would be
do-
difficult, but possible.
Do you think if we had a comprehensive database, that would actually improve surgical procedures, etc.?
Yes.
Definitely.
Yes. It's a question
Would
of
have been
getting
good
it
if we did it in
Yeah.
the first place. Yeah.
But to make it comprehensive, you also need to make it mandatory?
Yes.
So how do you make it mandatory? What mechanism do you use?
Same mechanism that the orthopaedic surgeons have used, which is peer pressure. There's not an orthopaedic surgeon in this country that would put a hip replacement in now without putting it on the National Joint Registry. It's not mandatory, but they just wouldn't do it because they have such peer pressure and result focus.
I don't know enough about hip replacement issues, but does that arise from the problems that have been associated with hip replacements, as opposed to clinical?
They had a similar spraying about of different prostheses, and interestingly, when you look back, everyone's comparing them back to the original and not actually getting better than the original, but inventing new complications, as I understand it, not being an orthopaedic surgeon. But I did get involved in the metal on metal scandal because that part of that involved the bladder. But so I think the joint registry predated the metal on metal thing, but that really ramped up the peer pressure and it has become essentially mandatory.
Given that the concerns around mesh go back now quite a way, why didn't it happen with mesh? The peer pressure. People were clearly concerned. We've seen that reported with documentary evidence going back from professional societies. Why did that happen? Those databases that have been talked about since 2003 never got off the ground.
I think there were issues of funding. So, people wanted a registry, and originally I think there was the ideas that Gynaecare would create a registry, which I think would have been unacceptable now, perhaps to patients. But I think it is. I think, answering your question about how you mandate it, I think it's really difficult to do that because it takes a lot of time, and we've been using the B-side database in the trust now. I mean, I've been using it since I was a consultant, but in this trust, we miss people, and we're real enthusiasts, and you sit down after the procedure and you put a patient in, but you get distracted, and we audit to see whether we've missed anyone, and we put them in, but it is possible to do that, and so there has to be some assistance to the process, and we need admin support, and I don't know, but the patients may actually prefer that we weren't putting our own data in. So I think we put it in at the point of doing the operation, and we write, we enter the database. But actually the outcome data, that I'm not sure that patients would be happy that we're entering our outcome data. And so it does need an amount of infrastructure and resource to do that within a hospital. And I think there are people who are enthusiasts for collecting the data and using the database, and there are others who may be, obviously not in this room, but they didn't see it as a priority, and they were perhaps not doing very many, and they didn't put them in. And I think now that the spotlight's on it, I think it will be easier to make that case as the orthopaedic surgeons have. But equally, it may be related to funding, that you don't get paid for doing the procedure if you haven't entered it onto the database, which I think will be the better way to do it.
That would provide greater assurance to the public.
You don't get...
Well, we've been thinking quite a lot about this, and what's been put to us is that you can have a database that actually just has a very simple statistics about what's happened, the surgeon, where it's taken place, what product was used, and so on. And it would be anonymised. So you'd actually put in the patient number, the NHS number. So from that point of view, the patients, I think, would not be too concerned. Well, we don't know, we'd have to ask them. And then we're saying from that, you could then lead on to registry, which would be quite different, which is where you do have to have the patient's name and consent, essential to have the consent. And then you can follow up the patient as you wish, year on year or whatever. Are you still suffering pain? Are you need to take the views of the patient. But, it's been put to us that you could have actually two very different sets of information. And one is simply about the data that's been done. And I think possibly with new technology, if you've got barcodes and things you can use, you could do it without having to put so much weight on the surgeon's time and all the rest, and I do take that. So we're sort of thinking about and seeking views about whether you think that is something that you might support.
Absolutely. It's well overdue. The way that the hip replacement one, the joint replacement one is funded, of course, is with a levy on each joint that's sold, so it's actually funded by industry, which is the appropriate place for the funding to come from, in my opinion.
And we've had nowhere really, until recently, the BSEP database has gone through various modifications, but we've had nowhere really to report complications. So you report to the MHRA, but it's kind of a black hole. It disappears in there, and you don't really know. No one makes you do that. So that would be useful, that we have somewhere to collect all of that stuff. So we tend to report surgical when we've removed a mesh, but I suspect we're less good at reporting the patients who don't end up with surgery, and so that the registry would capture those kind of outcomes that patients could report where they haven't required further surgery, but they have had an adverse outcome that could go on the registry.
And this would require follow-ups some considerable time after the original procedure to understand complication rates, long term as well as short term.
You either give, there's a few ways of doing it. You can give patients some kind of easy access back in if they think they have a problem, and we do quite a lot of telephone reviews. So I have some patients who have anxiety about their mesh, may not have wanted to have it removed, but they have anxiety that I offer them a telephone review. I'll say, look, I'll speak to you in a few months' time, see how you feel. And I think that's quite a good way of doing it. It does take time. Or if it's the whole registry for the country, and you wanted to find the outcomes, then, so we're not talking about my individual patients and how I'm looking after them, but you wanted to know the outcomes, you could take a sample of patients, saying we're going to look at these women after 5 years and we're going to do a sample of the whole database and contact them to get their results. Or you give them a way that they can get their own results into the database. And we use an electronic questionnaire that patients can fill in before they come to clinic, and we have their information. Now then, it may be possible to do that to feed into the database.
So have some kind of a prom or a friend that goes in automatically, not an electronic.
I think I'm going to have to draw this to a close, and I'm sorry that we've been a bit short of time, but that's how the world works sometimes. So I'm just going to ask my colleagues if they've got any final questions they'd like to put to Simon. Anything you'd like to ask us?
No. Don't think so.
No? Right. Well, thank you so much for coming. I'm really, really grateful, and thank you for all the work that you do. It's really, really appreciated, and I think in the NHS perhaps you don't get enough thanks. But, very much thanks.